Good evening, ladies and gentlemen, and welcome to the first of NCER's coronavirus briefings webinars. We were averaging two and a half a year last year, and we certainly expect to keep up that pace. This is the first of our 2021 webinars, and very appropriately, it's dealing with looking beyond the pandemic and what we need to do, not just to win the war against the pandemic, but also to win quality healthcare for every Indian. And this is really a book discussion and much more. We have a great pleasure of having Mr. N K Singh chair this meeting. N K Singh is, of course, the chair of the 15th Finance Commission, a renowned politician, economist, a top civil servant in the past, and a member of the Rajya Sabha from Bihar. A superb combination of policymaker, policy analyst, and I think, as the reports of the 15th Finance Commission show us, somebody whose heart is in the whole process of how the state can deliver services, including, in this case, a very special emphasis in his report on health services. And so it's a great pleasure to have Mr. N K Singh chair this meeting. Over to you, N K. Thank you.
Well, thank you very much. Thank you for Shekhar for the privilege and opportunity to be able to be present today to moderate a very special session of this great book entitled Till We Win, India's Fight Against the COVID Pandemic. We are fortunate in having all the three authors of this remarkable book, Dr. Chandrakant Lahariya, Dr. Gagandeep Kang, and Randeep Guleria. None of them really deserve any more than our great admiration. And I say this with repeated emphasis. And in today's context, we could not have thought of a better set of panel. Dr. Lahariya, of course, you have had this distinguished record both as a faculty and as a teacher, and have played an important role in writing this book. Dr. Gagandeep Kang, we are really fortunate in having you, not only given your great academic and domain knowledge as the first member of the Royal Society, and Dr. Guleria as someone who is the head of AIIMS during this critical period, and other panelists who are to join, if I may say, have also played a very important role. Devi Shetty, Devi, in case you are there, I want to also welcome you as having played also a very critical role. I'll come to that in a minute. And of course, Preeti, who is now in an important international kind of a vantage point, given her current position. But more importantly, I think that Preeti, you have the great advantage of getting a ringside view and having been in the ring yourself earlier in having crafted the contours of our policies which are currently underway and many which we are still unravel. So with these words, let me say one or two things about the book. I have gone through this book with a great degree of admiration. I have gone through this book with admiration because it deals in a certain sense with the past. By the way, I must compliment the author that I have not read a more fascinating account of the past pandemics, what we did to overcome this. It's a brilliant chapter on understanding the challenge. And then I have not read a more cogent account of what we need to do in the chapter relating to getting the future ready, and preceded by a chapter that never allow a challenge and opportunity to go waste. So I think in a certain sense, it spans a very long period of history. The reading of the chapter on the history of the pandemic does bring out the difficulties and challenges in having a vaccine in such a short period of time. If you read that chapter, you'll realize how much longer in earlier periods we've had to wait to place our trust in vaccines which given the power of what science has done, what technology has done, and what medical research has done, we have been able to put together a global response. So in the Indian context, I must also add that I'm fortunate in being able to preside over today's session because I had, as a chairman of the 15th Finance Commission, I had even before the pandemic realized that the health system in India was broken. It had been neglected for many, many decades. And even before the pandemic, as I said, had broken out, I had set up a group with Dr. Guleria as the chairman of that group. It had Devi as a member. Preeti had given remarkable support to that group. And there were others who were associated with the working of the group. And then the pandemic came, and which we therefore updated all those analysis and understanding. And for reasons which are now in public, will be soon in public domain, we were the first finance commission ever since our independence, as being the 15th finance commission, to have, in the circumstances, devoted a very special chapter on the health sector and what needs to be done as we look ahead. And also, I think, devoted, apart from the issues of the current challenges, what we need to do for the engagement of the third tier of administration. Many of us, of course, realize that issues of very low public outlays, both by the center and the states, the issues of distortion, spatial distortion, or this public outlay where the poorest states had even poorer infrastructure on health, given even India's low poor infrastructure, given the fact that many regulatory and other changes were necessary to improve the human development responses, the fact that we have in the past not given priority to according the necessary dignity of work to the doctors and the frontline workers who have been engaged in this, not only in terms of the doctors, but equally in terms of paramedics, what we need to improve the supply side on that, and what unconventional techniques can be adopted and innovations can be adopted to improve those kind of responses, which go beyond merely enhancing public outlays. And finally, what we need to do, something which both Devi, Preeti, and of course Randeep has emphasized, of the engaging of the third tier of our governance architecture, namely primary health centers, municipalities, urban local bodies, in giving the requisite priority to this very neglected sector. So I think that this book brings out brilliantly the past, the present configuration, and the challenges in redressing not only this pandemic, but in many such kinds of pandemics, which I do not think requires any further proof that this is a big global pandemic, but may not be the last one, since this is what humanity has encountered in its history over all these years. So with these little words, may I welcome all of you here, and may I begin by first requesting Chandrakant Lahariya, the author of this book, till we win, to make his comments, observations, or presentations. So Chandrakant, over to you.
Thank you very much, Mr. Singh, for kind words about the book. Really touched. Good evening, everyone. So my presentation is titled as Pandemic, People, and Public Health System. We know the Greek root, Greek word pandemic means all people. But there is something about all people, which is a public health, the art and science of preventing, promoting, and maintaining health of all people. So the title want to indicate that people are the center of everything we do in public health. And the pandemic affect people, then we have to strengthen the public health. That's the presentation is all about. This presentation is also about a few other P's, which is partnership, personal protective equipment, positivity, private sector, and many other things, which have been used extensively in this pandemic. Moving to the next part, that the world was talking about pandemics always. And it was forewarned that there would be pandemic, but probably or barely any attention was given. So we know that outbreaks and epidemics keep happening, but pandemics are rare. The last one happened in 2009, and it was not that extent. 2009, 10 H1N1 swine flu. But between 2009 and now, there were 6 disease conditions which were termed as a public health emergencies of international concern. These were designated by WHO, and they could have got into a pandemic scale, but we were fortunate. However, the experts keep talking about the disease X. They said that we don't know what would be the pathogen, what would be the disease, but that could be the cause of pandemic. And the warning or alert was strengthening health system, being ready for the pandemic, but we know that it was not sufficiently heard apparently. However, it was not all blank. There were a few things which were done. For example, the Coalition for Epidemic Preparedness Innovation was formed. So world was talking about pandemics. Probably we were not sufficiently preparing. We also know that pandemics are inevitable. They are inevitable, and probably or nearly every passing day we are moving, or we are increasing the risk or probability of getting into a pandemic. The reasons are many. There are new diseases which emerge, and then old diseases which re-emerge. And they re-emerge in the context of we are living in the world where we have a faster and more mode of transport. So within 24 hours, a person can move one part of the world to other part. So improved transport and faster transport. The rapid urbanization, which means we are living in the crowded areas and more contact between the people. The deforestation, which means there is an increased contact between the wild and the people. The viruses hidden in the forest till now are being exposed to the human beings. The climate change, global warming, pathogens which are entering to the new areas, surviving for a longer period. The kind of battery farming and single animal livestock operations at large scale. And the widespread use of antimicrobial, sometimes indiscriminate use of antimicrobial, which is resulting in the antimicrobial resistance. So there are many things going on which are creating a perfect setting which can result in pandemic. So nobody can say that we were not warned. And there are few things which are outside health sector, which has resulted in the pandemic scenario. So in this setting, in January 2020, nobody had thought that we would be in a situation which the entire 2020 was. And we decided to write this book in that setting because we felt that if we don't write, it would be a missed opportunity. There were many reasons. We knew that every stakeholder, from top level policymakers to general public, journalists, and anybody, pandemic is about all people. Everybody was affected and talking about health. But we thought this is a medical care perspective, health is not being fully understood. In the beginning of pandemic, a lot of discussion was happening about health system strengthening. But as 3 of us as authors, we felt that understanding was incomplete. And if at this opportunity, we don't talk about the correct understanding of health system, probably we will be missing a lot. But also beyond these macro objectives, we were also mindful that pandemics are fought with the right information, empowering people with not only telling them that what to do, but also telling them why they need to do what they are being told to do. So that kind of empowering information we wanted to include in the book. We also were mindful that why a single book should be written for both policymakers and general public. And our idea was to bring a sort of social accountability, that if general public know that what policymakers, elected representatives are supposed to do in health sector, or whether they are doing or not doing, that will bring a form of social accountability. So that's why we have this chapter on, which is a little technical and macro on strengthening health system. But we think it's an important chapter that people know that what government should do, and that will, some of those people who will read might become a future policymaker. But this is an important tool, a book for a social accountability. That's what we thought. And also the reason we decided to go ahead with writing this book, in spite of our busy schedule, all of us were involved in different roles in the pandemic response. But we thought it's important to step back and have a as you correctly said, Mr. Singh, a ringside view or a balcony view where we see as a neutral observer what is going on all around. And that's what all the things we thought, and that's why we decided to write the book. Now, let me quickly reflect that when we say that the understanding of health system, the way it was being discussed during the pandemic was incorrect. What do we mean? And so this is a standard health system framework as designed by WHO and widely used globally. We know the health systems are with a specific purpose, that people have improved health outcomes, the inequities are reduced. We know health systems are designed so people don't face financial hardship or financial risk protection is there. But that what you see on the right side, the goals of health system can be achieved or are achieved when there are a few functions or building blocks are followed. These functions are on the left-hand side of the slides. That to achieve the final goal, you need to have a good leadership and governance for health sector. We need good funding, healthcare financing. We need human resources. We need medical products and technology, information, research and data, and service delivery. But if we go back to the early part of the pandemic, much of the discussion in context of health system spending was about increasing hospital beds, extending laboratory services, and a bit of discussion on maybe increasing some government funding on health. It is widely and globally known that all 6 building blocks need to be intervened in the right and balanced combination if we want to improve health outcomes. So much of the discussion or discourse during the pandemic was on service delivery. That is the last part, that hospital beds or increasing testing services, a bit on medical product and technology. They say, like experts say that we cannot say that how much we need to intervene on each of the blocks. That will be decided upon the local situation, but we need to intervene on each of the function of building blocks to improve health system. And that's what we wanted to make. And that's how the chapter 10 in the book is structured. Moving quickly. So we know that we will win the battle against this pandemic. But in our opinion, this battle would be incomplete if we don't learn and intervene based upon these learnings. In this book by 2013 Nobel laureate Angus Deaton, The Great Escape, he has argued that much of the economic development in European nation and OECD countries happened because they learned from the 2 pandemics which happened in 1817 onward and 1899. He has argued, Mr. Angus Deaton has argued that after the first cholera pandemic, which was in 19th century, much of the development and sanitary movement started in Europe, which improved the health outcomes and then also facilitated the economic development. Similarly, after the influenza pandemic of 1918, European nations started paying attention on health services. So he has argued that it was the learning of European countries after 2 pandemics to strengthen health services, and that's what has contributed to their economic development. We think, and it can be argued that probably that kind of learning did not happen in India or Asia. However, when we were in the 2020, when this pandemic happened, a few years before that, in 2017, India released in country's latest and 3rd national health policy. This is the first policy which comes with a detailed situation analysis document. And I would argue that this is one of the best situation analysis document where government has categorically acknowledged the challenges and limitation of Indian healthcare system. So if you know the challenges and limitation, that is the beginning of the solution perspective. So this pandemic is happening when challenges were already known in Indian healthcare system and some attention was given on improving or tackling those challenges. But pandemic became another reminder that we need to act faster. And so what were the learnings from this pandemic? And I would reflect a few in allowed time, and then my co-authors would be discussing other aspects. So one of the learning I would argue is that people have been the real core of this pandemic response. We know that while testing, tracing, and treatment were the intervention which has contributed to pandemic fight, we also know that the non-pharmacological intervention, face masks, hand washing, and physical distancing. But the success of all these interventions was not dependent or only partially upon health systems, but largely upon how people behave or their participation. There are many studies, and we have documented detail in the book, that it is the community participation and engagement and accepting these COVID appropriate behavior, coming for the testing services, supporting and cooperating for testing, and coming for treatment early. That's what has contributed to the success of pandemic intervention. The difference which we see between in the pandemic and the COVID-19 cases or cases in many Asian countries and Europe and USA can very well attributed to people's participation in these different settings. So different epidemic curve is associated with the citizens' behavior and adoption of non-pharmacological intervention. We know, and at some point of time in India, there was a discussion that irresponsible citizens are contributing to increased pandemic. But now when we see the reduced cases, we should give credit to those same people that they have contributed to the pandemic fight in the country. There are potential learning from these people's participation in this pandemic. For example, these learnings can be used for the ongoing silent pandemic of non-communicable disease. They are also can be tackled by some of the intervention which people have to adopt: a healthy diet, regular physical activity, no smoking, or no or moderate use of alcohol. So we can carry some of these learning that how to engage people in health services. The other learning from this pandemic is that healthcare is not just medical care. Medical care is about sick people, hospital-based care. To keep people healthy, we need public health. The difference between some of the countries, again, even Asian countries which are doing well, on United States, other countries, that they don't have that kind of public health infrastructure. And with the medical care structure, they are struggling. So healthcare is very different from medical care. And to keep people healthy, we need healthcare. And this healthcare is delivered with the public health intervention, preventive, promotive, curative, diagnostic. And we need to re-emphasize these points. The best approach, and the countries which have succeeded in delivering public health services, tackling pandemic, are the one which have a primary healthcare facility in which they have invested over the period of time. Governments have invested, they have created public health systems. So the second learning is that we need not to, and we should not focus on medical care only. We need healthcare for people to keep societies healthy and also to fight pandemic. The other part of this pandemic and the key discussion has been that which system can fight pandemic better. A country cannot start a healthcare system de novo. It has whatever type of healthcare system, and India has a mixed healthcare system where private sector is a major provider. But we have also witnessed during the pandemic. In the early part of pandemic, it's mainly government healthcare facility which were delivering all the services, whether contact tracing, testing, or treatment services. Slowly, private sector also joined and started delivering those services. We also know that the cost of those services in private sector when the COVID-19 pandemic services started was excessively high, so much so that even the regulatory bodies were not paying that much amount of money, and government resorted to price capping of both treatment services and testing services. Of course, the government provided a large part of broad range of services, but private sector mainly provided testing and treatment services. This, for example, is one of the rare time in Indian history where price capping was used, which is an acknowledgement that the prices were high. And even after price capping, the private sector did not resort to refuse or protest that much. It is also an example where healthcare regulation was effectively used. But private sector has another important role, which it played in the development of PPE or getting the PPE ready, testing kit, and vaccine development, all these things. So we have a different role for different sectors with appropriate regulations, and there are learnings. Another learning which emerged from this pandemic is that we need to reflect upon that should we continue to follow the biomedical approach to health services or need to pay more attention on social or behavioral science. A lot of focus has been that we try to find solutions to health problem in medical or biological approaches. The discussion that why India has low mortality and why pandemic is low are being explored in BCG vaccination, past BCG vaccination, or we are deliberating that there is a hyperactive immune system because high rate of underlying infectious diseases. But we also need to see that are we missing some social or behavioral aspect? India and people adopted those kind of behavior, and that's why it is making a difference. Maybe it's only the minor change in the behavior which makes a bigger difference and which we are not acknowledging. How and why communities participate in it, that's something which we need to learn and keep in the mind for future. One of the learning and one of the things is that why government need to increase spending on health. India's health spending, government spending on health is one of the lowest in the world. And in spite of the policy commitment, the funding has increased only marginally. Like it was 0.9% in 1990 of GDP, and now it's 1.18% of GDP. Similarly, we also know that between year 2001 and 2, the state government spending on health as proportion of their budget was around 4.5% of GDP. And by 2015 and 16, it increased only marginally to 5% of their GDP. Though even in earlier national health policy and even 2017-18 policies say that around 8% of state budget should be spent on health. So we need to explore that why there is no appetite to spend on health. And this is happening in spite of the economists around the world has shown the evidence that for every dollar or every rupee invested on health give 10 times of return. Economic development and linkage of health is so widely known. You need a good human capital. So investment on health is the wisest thing around, but still why governments are not doing. How to change this status quo? And this is happening when millions of people cannot afford healthcare. So we need to reflect once again after this pandemic. Another learning from this pandemic is that urban settings are more prone to infectious diseases. And the origin is in that slide, why overcrowding and then other behavior are there, but also the social behavior, other aspects we need to explore. But I want to bring attention and urban-rural difference in pandemic outcomes, but also in health agency, that there is a very limited clarity till now in who delivers healthcare services in urban area. The 73rd Constitutional Amendment designated or assigned the responsibility of primary care and public health to urban local bodies. However, most of the urban local bodies spend on health, which is less than what they spent on street lighting. And that resulted in the primary health care, or primary care is the weaker in urban area than the rural areas rather. So we need to relook and once again examine. The urban health services are more of a medical care. The rural health services are more of a health care. The level of community participation and engagement in rural areas is far better than urban areas. So there are many learnings, and there could be the difference in the pandemic response during this period. With all these, and I would, in interest of time, I would restrict my points to these only. And there are a few other aspects that this pandemic has also taught us that the pandemics can be fought by health as a teamwork between health workers and non-health workers. So while the doctors, nurses, and sanitation workers have worked in the hospitals, the frontline workers, mostly women, the accredited social health activists, auxiliary nurse, midwife, nurses, Anganwadi worker have been at the center of this fight in India. And this book, Till We Win, is dedicated to these frontline women healthcare workers in India. And of course, the credit is to everybody, but they have done a lot of human service and work in this area. Health services entail teamwork, and we have seen that how even for the COVID-19 vaccination, we need a teamwork and working together. This is not all that bad. There have been many silver linings and which have been discussed in the book. This has provided, pandemic was really difficult and hard on everyone, but it has provided us an opportunity to give a renewed attention on health services at all levels. There have been more than ever deliberation on strengthening health system, and that deliberation and discussion by top level political leaders strengthening public health services. One of the revelation and one of the development after this pandemic is that the importance and relevance of mental health care services has been recognized. And I really wish that it will improve those services. The teleconsultation has been legalized, which is its own good opportunity. The hospital beds and testing capacity was ramped up, which is a proof that if government is willing and desirous, it can do and achieve a lot in a short period of time. Similarly, moving from zero PPE production capacity to testing kits to going into self-sufficiency, which also reflects the kind of shortages in medicines and supplies we see in the healthcare system, and which also shows the potential that if government is willing and desirous, it can address those challenges. Of course, the research and development, the rapid pace on this area, and the way vaccines and testing kits have been developed is really remarkable in this period. The newer collaboration and partnership between policymakers, health experts, and community members is fabulous, and we hope that this would be continued in the time ahead.
Thank you.
Yeah, this is last slide, and then so getting to this part, that we have learned many of this thing, and we know that we will win against this pandemic that is given. However, the point is that how to sustain the political attention and momentum which we have received or which have gained about the health services in India, how to sustain that to transform India's healthcare system. And that is our joint responsibility, and that is possible. And that should be done today onward. Thank you very much.
Thank you very much, Dr. Chandrakant, for that exceedingly useful and informative overview, which covers different aspects of the challenges and the opportunity and the sort of responses which would be appropriate. I now move on to requesting Dr. Gagandeep Kang, who, as I said, requires no introduction, to make her observations and comments on the subject under discussion, and more particularly as the author of this important, fascinating book, which has been written in such a non-technical way that it would be a compulsory read for any average Indian who may or may not have a technical knowledge. It has been written in a style which is exceedingly, exceedingly readable. So can I request you, Dr. Gagandeep Kang, to make your brief observations? Gagandeep.
Thank you so much, sir. I'd just like to say very briefly that I think this pandemic in many ways has been very good for us, because despite the toll that it has taken on people and on systems, there is an increased recognition of the importance of stronger health systems and of research. And what I'd really like to focus on is all that has been done in the country by the government to highlight the research that is required. So if we look at the virus itself, we actually don't have a lot of virologists in the country. And what has happened is that a lot of basic science institutes like the Indian Institute of Science in Bangalore, the National Center for Biological Sciences, the Center for Cellular and Molecular Biology have begun to focus on structural studies of viruses. They earlier had a lot of ability, and Indian scientists are really fantastic. So to see them turning now to what are really public health problems has been phenomenal. And if we think about what has been done in terms of vaccine development, indigenization of diagnostics, thinking through the making of new equipments, I think our industry, academia partnerships have been excellent. The area that bothers me that I think we need to do more on is clinical research, because I think the quantum and the quality of clinical research that is done in the country, of public health research that is done in the country, has been really quite limited. When we wanted mathematical models for predicting what was likely to happen in the country, for the first few months, we had to rely on models that came largely from outside the country, that were developed by a lot of mathematicians who actually had no understanding of infectious disease and frequently got things quite wrong. And if we look at clinical research and we look at what's happened globally, India's participation in the Solidarity trial was really quite limited. Given the number of cases that we had in the country, we recruited very tiny numbers. And if we are to do better the next time around, I think focusing on building clinical research capacity so that we can do large, well-powered studies on diagnostics, on vaccines, and on drugs would be really very useful. But I think at least all of this has been highlighted. And since the lights have gone off in my house, I think this is a good time to hand over to you and to Randeep.
NK, are you having some technical difficulties?
The electricity is back on, but back to you and to Randeep.
Okay. Gagandeep, do you, no, since the power is back on, do you want to finish up? Is there anything else?
No, I pretty
fine.
much said what I wanted to say, okay. And I do want to leave time for questions.
All right. So, I'll take over from NK as he's struggling with some technical difficulties at his end. Very pleased to have you, Dr. Guleria. You run AIIMS, our premier medical establishment. You've gone through it all. Tell us what drove you to write this book and why it's so important for the future of our country.
Okay. So I'm back. I also had a little technical glitch. Shekhar, apologize. I now request Dr. Randeep Guleria his comments and observations. Randeep, on this is not one of those television sessions in which we are always fortunate to see you, always dispelling doubts, adding to information. But this is about this rather serious technical work which you have undertaken along with your other two co-authors. So over to you, Randeep.
Thank you very much, sir. And it's indeed a pleasure to be here. I'd also like by really starting and thanking my co-authors. A lot of work has been done by them, especially Chandrakant, and he's been the driving force as far as getting us all together for this book. And therefore, I think acknowledgements are due. This book was basically to really highlight the challenges India faced and how they overcome these challenges as we went along the pandemic. This pandemic was something that, as has already been said, we've been talking of a pandemic since we had bird flu or avian flu H5N1 almost 15, 20 years ago. But at that point in time, when we had outbreaks, which we are now having again in Maharashtra, in Bengal, and in the Northeast, there was this whole concern that H5N1 could become a pandemic, influenza pandemic, and it has a very high case fatality rate of more than 60%. So I even remember at that time we did workshops and trained primary health physicians on ventilatory management. The ministry organized that, and how would we manage patients on ventilators? And there was a proposal to have 3 ventilators in each district center as a part of preparedness for a pandemic. But as things evolve, I think we never were able to sustain it. So I think this book tries to describe the challenges that one can face, especially in a country which has already got a stretched healthcare system. We need to accept that we are really having a healthcare system which is stretched. And yet, despite that, we, I think, did pretty well as far as getting our resources in place, making sure that we didn't have a shortage of oxygen or ventilatory points, and also training enough staff so that we could really manage the pandemic. We had a huge challenges, as was mentioned. Testing was a huge issue in the beginning. Very few labs were testing. We were doing too few tests. And then gradually we built on that. A lot of people came together. I must say that we made it mandatory. And I think this is one achievement which will be sustainable and should be very useful. We made it mandatory for all medical colleges to have a basic immunodiagnostic lab. And that was something which the Medical Council of India actually passed as a direction. And that I was involved in that. We took meetings regularly. And I remember that we had to even write letters to certain medical colleges that we will cancel your license unless you get this lab going, because it meant you had to put in some degree of investment. But because of that, we had now more than 2,000 labs which can do testing. And this would be something which will be useful in the future, not only from the virology point of view, but for a large number of immunological testing. So a lot of things that we sort of went along and learned and were able to do, which showed our resilience and showed the challenges that we have. I remember the early days, there was a huge panic about shortage of PPEs and N95 masks. And then how industry and everyone came together, and now we are actually exporting PPEs and N95. But at that point in time, in our own institute, we started doing studies and we published a paper of how can you recycle PPEs. Although I still feel it's not a bad idea because there is a lot of wastage as far as plastics is concerned. One of the drawbacks of this pandemic has been the effect on the environment. The huge wastage, or the huge all of the gains that we had in the past of having decreased our plastic consumption has really gone up over the last year. So we were thinking that it may be not a bad idea if we could have PPEs could be recycled. At least it would help in terms of the plastic wastage and the disposable that we're having going along. Treatment also, I think we were aggressive in trying to look at treatment. Some of them worked, some of them didn't. Hydroxychloroquine, of course, created a controversy, but that was something that we pushed for in the early days. And it went on and we were able to manage. Even I remember there was this whole shortage of remdesivir, and then we were able to get Indian manufacturers on board. And remdesivir is now easily available and at a much cheaper cost than what it was going to be initially marketed by Gilead. So a lot of things we were able to do. But what were the learnings? I think the main issue now is what was the learning as we go forward? I think the first most important learning is that there has to be more investment in public health and in the public sector. That is something that we've been lacking for a long period of time. And although we've talked about it a lot, it's not something that really is happening as far as ground reality is concerned. And I know that the 15th Finance Commission has also pushed very aggressively for this. But I would be very happy if the pandemic does one thing, that it becomes something that we are able to see really happening. And when we talk of investment, I would say it has to be a lot on primary and secondary care. It's not going to be that much if we start focusing everything on tertiary care, high-end machines and high-end technology, but we need to really focus a lot on primary and secondary care, preventive health, and that is multi-sectorial. But a large number of diseases could be controlled very well by just preventive health, and we are actually not investing as much as we need to do in preventing health. The other is the learning that we've had is we need to develop infrastructure, especially in the public sector. We really have had huge issues in that, and especially as far as rural India is concerned, small cities are concerned, there is a huge constraint as far as investment in health is concerned there, and therefore a lot of patients from North and Central India travel thousands of miles because they don't have a good healthcare facility available really close to their house. And that really causes a huge expenditure, leads to a lot of loss of work hours, and is something that we need to look at very, very holistically. I also think we need to look at human resources. We focus a lot on doctors, but there are other ancillary staff which can do a lot and can help us as far as developing our whole system is concerned. Dr. Chandrakant Lahariya mentioned about ASHA workers, but what about our nursing staff? What about the technicians? Many of them can really be empowered to do a lot more than what they're doing right now. And that will really help in providing good quality care. There's also the whole issue of integrated health, which becomes something that is, to some extent, a strength also. We need to look at that. For example, in our setup, we talk a lot of pulmonary rehabilitation, but we've shown that even yoga is as good as pulmonary rehabilitation and is much more cost effective. You just need a yoga mat. You don't need a treadmill. You don't need a bicycle ergometer. So we need to look at our own solutions in a way that would be practical and cost effective. And as Gagandeep mentioned, one other learning was that we need to really focus on research, something that we've not done, and we've not really helped in developing a research cadre, or I would say a clinical research cadre. A lot of people come to AIIMS and would like to go into pure research, do research which has a translational element, which can be something which can be useful for the country, but there is no path for their growth. What will they do? Will they be able to have a career path as far as this is concerned? We need to develop a good career path for our researchers so that when they go into research, especially clinicians, they know that this is a good career and this has a future. In our country, that is not there. If you don't get a research project, if you don't get your funding, You may be on the road. We really need to develop some sort of a mechanism that we promote research. And when I'm talking about research, it has to be intersectorial research. We have to come out of our silos. Research has to be with mathematicians, it has to be with engineers, it has to be with computer science. Now, research is something which goes beyond your own dimensions. If you're talking of artificial intelligence, you will need a lot of people to involve. If you're looking at bioinformatics, if you're looking at genomics, proteomics, you need to have a lot of basic science and other researchers together. We've never worked in that direction. And I think one felt that if we had all of this in place, we would really be right up there as far as research in the pandemic is concerned. Learning has also been that we in medical sector have not really harnessed technology as we should. One of the major lessons was telemedicine and teleconsultation. It became something which many people were forced to do rather than doing it as a routine. But it showed that the power of technology, that you could really reach out to people and provide them care without them having to come to the hospital. More cost effective, better sort of utility of time. And this is something that we could have done. So I think what we've learned is that technology, if we use more aggressively in medicine, whether it be simulation-based learning, telemedicine, teleconsultation, or using a lot of current devices that we have. We all have our Fitbits, our phones, which tells us our ECG, our heart rate. Why can't we incorporate that into a health-based system which helps to predict the future and diagnoses your heart problem before you actually have a heart attack? So a lot of this can be done. It's not rocket science. It's already there. Since we've not been able to really coordinate everything, we were not able to do that. So I think there is a lot of learning that we've had from this pandemic. And I hope that we sustain this and we're able to take this learning forward. It doesn't die down as the pandemic dies down, because it often happens like that. Thank you very much.
Thank you. You're muted.
Thank you, Randeep, for those very useful overarching remarks. I share, and I have shared many of my concerns which are common, and hopefully many other points which you have raised, which have been addressed by us in our recommendations and award in the 15th Finance Commission, of which you have been an integral part, as indeed Devi and Preeti have also been very integral to it, particularly on the emphasis which you have placed on human resource development. I mean, not many of us know that we may be among the extraordinary countries, and Gagandeep, I'm sure this will not surprise you, that we don't have an Indian health service, even though Preeti brought out dramatically in a presentation she had made to me that this is provided for in the Civil Services Act of 1951. Now, from 1951 to 2021, we have not acted or to create a national health service. And many of the doctors are still on contractual appointments, which rightly Sandeep has pointed out would be a strong deterrent for people who are seeking a gainful career and are seeking greater comfort, predictability against what lies ahead. But we will all have many questions to ask. I am now going to request Devi. Devi, you have been part of the discussions. You were an integral part of the group which advised the Finance Commission. So over to you, Devi, and it's good to see you in good shape as usual.
Thank you, sir. Thank you so much. I would like to congratulate the authors for compiling everything revolving around COVID-19 in such a short period of time. If we have to write a book, anyone has to write a book on COVID-19 across the world, which country has performed the best? I have no doubt that India will be voted as the country which has performed the best. Why I am so confident to make that statement? Because the performance of a nation is not based on how many beds you have in the ICU, how many ventilators you have. It only depends on how many people died following COVID. And That is the single proof to say how the Indian health system managed to manage COVID-19. If mortality is the single indicator to know how each country has performed, we have performed the best. I have no doubt about it. Now, let's see how the various indicators will progress. Like every pandemic, there are a lot of bad things happening due to pandemic, but a lot of good things comes out of pandemic. Let's look at when the pandemic just started, where we were and where we are today. When the COVID-19 started becoming a reality in India, we had 30,000 ventilators. A country of 1.3 billion people with 30,000 ventilators, I guess significant number of them were not working. And we were to face that many flood of patients who may require a ventilator. 2 months later, we were in the process of producing over 30,000 ventilators, just in 2 months. I will tell you my personal experience, why this is important even for the country. As a company, we buy one of the largest number of medical equipments in the country. We have got huge, hundreds and hundreds of ventilators everywhere. The moment COVID happened in India, I called the CEOs of 3 biggest international ventilator companies, asking them to supply our company at least 200 ventilators. All of them uniformly, flatly refused to give us the ventilator. I was taken by surprise because I took them for granted. I thought we are the largest buyers and they have to supply to us. They said, this is the policy of our country. We cannot let go of the ventilator. Whatever is made in our country, it has to stay here. And that is the day I decided that if our country doesn't become self-sufficient for medical equipments, we have no future. This is the not having our own capability to produce life-saving drugs, not having our own capability to produce life-saving machines, equipments, and the support system, and the people to manage our the illnesses. Believe me, this is the greatest national security threat. And how this country has managed. One is the ventilator. On the other end, it was the PPEs. I was so ashamed to see the photographs of doctors wrapping themselves with the trash bin liners and covering their face with plastic and taking care of COVID patients. In just 6 weeks, we were in a position to produce more than enough number of the PPEs. And today we are exporting PPEs. This is unbelievable performance by our entrepreneurs and the Indian industry. The way the production geared up and started rolling out, this is nothing short of what US did during the World War. It's a truly a transformative change, what we notice. 17 years ago, I was sitting on this chair. I was treating patients in remote locations through telemedicine, using online telemedicine care through the cloud. The world didn't hear what cloud was until recently. And I was treating patients because Indian Space Research Organization gave me the satellite connection between our hospital and the hospitals in northeastern states. I treated 53,000 patients before people started hearing what cloud was. But it was illegal. Telemedicine was illegal. It was not legally allowed. 2 weeks after the COVID broke out in India, telemedicine got legalized. Today, sitting on this chair, I treat patients in all over the country. And those patients are not sitting in front of me, they are sitting in their bedroom. This will have a massive change in the way healthcare is delivered. Because believe me, in the next few years, the first consultation for headache to heart attack to any problem will happen online. I have no doubt about it. Then the greatest transformation which happened was medical education. The national board with the health ministry intervening with the advice of the leaders like Dr. Guleria, Dr. Vinod Pal, launched diploma courses in broad specialties. This will have a truly transformative impact. With one stroke of the regulation, over 1,000 hospitals run by the government and the private sector with over 100, 200 beds will become a postgraduate institution to train future doctors who can anesthetize patients, who can interpret CT, MRIs, and who can conduct delivery by cesarean section. This will have a massive impact on the way healthcare is delivered. So essentially, I would like to sum up saying that whether I may not attribute everything to the COVID, but it's the right policies decision taken by the government, I have no doubt that within the next 5 to 7 years, India will become the first country in the world to dissociate healthcare from affluence. India will prove to the world that the wealth of the nation has nothing to do with the quality of healthcare its citizens can enjoy. If there is one country in the world which can do it, that is India, and I'm very, very proud and happy to be part of this glorious journey. Thank you so much for the opportunity.
Thank you very much, Devi, as usual, giving many of these examples which are very telling. And as usual, many of your anecdotes have embedded in them a larger social story. You ended your presentation by a remark which I'm sure will resonate with us of dissociating affluence with healthcare. There cannot be a more egalitarian movement in this country if, irrespective of wealth, a minimum degree of healthcare and its affordability becomes available to an average Indian. So thank you very much, Devi, for those very brief telling comments. I now request Preeti. Preeti is currently advising the WHO in many ways. Preeti, as a former health secretary, laid the foundations of what many of you have acclaimed really to be India's success story. Preeti was intimately involved in the entire story which has led India to this present position. She was also intimately involved with finalizing the deliberations of the 15th Finance Commission and handed over all her knowledge and domain skills to her successor. So Preeti, over to you for your comments.
Thank you, sir. And thank you to all the three authors for an incredible book. I say incredible because for technical experts to write a book that is readable by all is nothing short of a miracle. So when I got this invitation from Dr. Shah, I had no clue on what the pattern of the book would be. But one thing that I would like to say is that you have made it a very readable book. And that's important because the way you have formatted it, you know, having boxes relevant to both the practitioners, the experts, and the general public. And I really appreciated your FAQ section because it clears doubts of lay public. So congratulations on that. I will limit and focus my remarks on strengthening of the health systems, which was a very critical part of your book. Dr. Lahariya very aptly put it that we cannot let this pandemic go waste. And I want to assure you that this government, and with Dr. N K Singh sir here with us, we will ensure that it won't be so. And I begin by saying that, you know, we have always, there's a saying that health is a public good. But I would say that health is now a global good because we are all interconnected. So you have mentioned about the 6 pillars or the 6 founding, I would say themes that a good health delivery system should have. Dr. Lahariya also gave it in his presentation, WHO has highlighted. But one thing is missing, which is community engagement. And from my experience, and that's what you have also very rightly acknowledged, Ashas and the frontline workers as the main COVID warriors, you know, who actually fought the battle for us. We were making policies, we were treating, but they were the ones who were actually facing public at large. So what worked in India was also, you know, community engagement through community collectives. So this is what I'd like to emphasize. That you see the VHSNCs that we have, the village health, sanitation, nutrition companies, nutrition committees, then, you know, the MAS, the Mahila Arogya Samitis. So these, the local self-government bodies that deal with health at the village level, these have also played a very important role. And while releasing funds for COVID in particular, I would also, through the NHM, release these untied funds to them. Because for sanitation, for emergency response, so this is one point that I'd like to add to your narrative. And next is that very rightly, I think we have now been speaking since 2017 about not only health as absence of disease, but health as wellness. And we were the only country actually who started speaking about it, not only in policy, but also in programs. So I think I was very fortunate to be health secretary at a time when this 2017 policy got translated into programmatic intervention of Ayushman Bharat. You see, we had been talking about wellness, but how did we do it? In fact, wellness was there also in the Bhure Committee in 1943, but nothing happened on that. So this whole concept of health and wellness centers, this whole concept of preventive and promotive health, I think Dr. Guleria spoke about it and Dr. Shetty also mentioned that the preventive and promotive health of how we can actually prevent catastrophic incidents is now very important. I'd like to share with you some data that I'm privy to. These health and wellness centers that I had been, and Dr. N K Singh sir knows that my whole presentation had that basic, you know, emphasis because public health begins there. And you know, it's very interesting that we are talking about equity. Dr. Devi Shetty spoke about, you know, very proudly, and I feel very proud as an Indian also about how that affluence is not what determines good health, but it is access, it is affordability, and also it is quality. So these are the 3 things that define actually our public health systems. So we have today 53,000 odd health and wellness centers. And every Monday, the Health Ministry actually updates the footfall. And you will be surprised that this footfall is today, I mean, this Monday, 32 crore people have visited health and wellness centers. And what I'm trying to say is that it's the equity part, the gender equity part. You see, you won't find many women visiting hospitals. Access to health with the gender barrier. But in health and wellness centers, the female footfall is more than the male footfall. So why I'm emphasizing this is that the nearer the public health facility to the residents of the public at large, the more you see gender equity and also equity in terms of income will be automatically ensured. So all this movement in India of health and wellness centers, of NCD screening, of Fit India movement, Eat India movement, multi-sectoral convergence, the nutrition mission, because I very rightly, I think one of the speakers also said that health is not just health ministry or doctors or nurses dispensing health or treatment. It's also about being fit, also about individual responsibility, also about accountability. And when you talk about accountability in this system of health and wellness centers, we have incorporated social audit. Social audit by panchayats, because already the rural development has a system of social audit by the panchayats. So these are some of the things that I wanted to say. Another thing which I think Dr. Lahariya didn't speak, but which I found very, very important in the book was that, the small clinics, the family clinics, the small hospitals have played an enormous role in providing essential non-COVID treatment. Now, I just want to inform this August gathering that these clinics, that health for the first time is now part of the MSME paradigm. So in all the Atmanirbhar, package, the small clinics have also been included because they are very important. Again, why they are important? Because they are close to the people. So the access is important. Access is more, and affordability issues are also actually, I would say, addressed there. Then Dr. Guleria spoke about that, we need more health providers. We need more people other than just specialist doctors. They can't be available all the time everywhere. So of course, with this telemedicine, with this e-Sanjeevani, 13 lakh consultations till we started COVID. I mean, you will be amazed to know already when we re-engineered this e-platform, e-learning platform of medical colleges that we have created into a teleconsultation platform. The response has been tremendous, and Dr. Shetty is privy to it. So I would like to say that this NMC bill, because you see, it's a very complex interplay of many factors. You are wanting to do something. Do you have legal backing? Do you have legal backing? Do you have a act to back it? Do you have the administrative will? Do you have the funding? So all these complex matrix of everything has to fit and everything has to be available at the right time. I think the NMC bill has come at a time when we are looking at community health providers, and Dr. Guleria also knows that Section 32 of this Act allows limited private practice to these community health providers. We have also made changes in the nursing curriculum so that all the nurses now graduating from, since 2020, graduating from the nursing colleges will be able to function as community health providers. So lots is going on, and I think in a way I agree with Dr. Gagandeep that this pandemic has had one very positive fallout, which is making health center stage. And it had to be center stage because we keep saying health is wealth, but we never sort of implemented it in policies and programs. But I think now is the time when the whole world is acknowledging it. As far as financing is concerned, I think very important also is how are these funds used? USA has 18% of GDP goes into health funding. But you see what US is doing today. So they don't have a good primary health system. They don't have a any outreach system. They have an insurance-based system, which is again more hospitalization focused. So I think the book very rightly brings out that it is the primary healthcare, it is the preventive, it is the promotive, and now and I also want to tell you that when I asked for money in the 7 months that I handled, COVID in the initial till July end, I was able to get for all the funds from the finance department.
Thank you.
And, I thank Dr. Singh sir also on that. And I just one more last thing I want to say that since the chairman Finance Commission is here, that yes, backwardness and criteria is very important, but also criteria on what is your performance. So the composite health index that I have been talking about is very, very important, because the states should be incentivized that they have to perform as far as health parameters are concerned, then they will get their money. So that incentive-based system of funding also needs to be looked at. So I think my time is up, is it? Okay.
Thank you very much, Preeti. But let me just make this comment that you are, as usual, very persuasive. You were very persuasive to the 15th Finance Commission. And both these last points which you made, namely the emphasis on strengthening the healthcare at the primary level and the engagement and adequacy of resources with the proper use of those resources at the cutting edge, namely at the third tier and urban local bodies and panchayats, that has indeed did make a big difference in our approach and thinking, which is going to be reflected in our report. And I think many of the other points which you have also mentioned have really carried persuasion with the Commission, which you will see when I'm officially in a position to say that this report is in the domain. But you were very persuasive with us then, and equally you have been quite persuasive in many of the points which you have made, including the fact of the far-reaching changes brought about by the new act on in Parliament, creating the National Commission, superseding the earlier body. Of course, it remained your quest. I have reminded the Union Health Minister several times that he needs to redeem his promise of getting the other bill relating to allied workers and allied health enacted in the Rajya Sabha. I have made my recommendations in the sanguine hope that he will stick to this commitment, which will free up the allied sector in a very significant way. Now, with these words, then, can I request now Shekhar Shekhar, you are muted. Would you like to make your remark? You are the only professional, I take, health economist here. You are an iconic economist. You are heading such an institution, or perhaps India's #1 leading think tank institution. You have given this an amazing, distinguished, continued leadership. And as an economist, both on macro and micro, many of the points which have been raised do deserve some comments by you. Over to you, Shekhar.
Thank you, NK, and really fabulous to hear such distinguished panelists, both medical professionals as well as public health specialists. I'm going to only make a few points. I think it's been a very rich discussion with Dr. Shetty, including in his OT garb. It's good to see a working professional participating and jumping between the OT and the webinar. So great to see everyone. The first one I want to make is that I think we've done remarkably well. I don't think back in March or April or May, we felt that we could quite survive the pandemic. And so I think everything that everybody said with great enthusiasm And great credit to our medical professionals and our policymakers and our suppliers of ventilators and PPEs and N95 masks. Really kudos to them. And I'm sure that in the eventual voting, India will emerge as one of the key players that has changed the way in which we will handle future pandemics. With that said, let me just make the point that the United States spends the largest share of its national income on healthcare than almost any other country. Yet it provides, perhaps relative to its wealth, one of the poorest healthcares in the world. So there is no real relationship that we see in the data when we look across countries that says that the more you spend on health, the more and better your citizens will be in terms of their health. There are ways of ensuring good health at low incomes, and there are ways of spending large sums of money to no purpose. So while we want obviously greater public and private resources to go into healthcare, the health policy of 2017 talks about 2.5% of GDP, we need to be extremely careful that we don't throw good money after bad. That we must think very hard, and the pandemic teaches us so many lessons about how we should spend that money. Simply going to a higher percentage of GDP is not going to ensure health for all, is not going to win the big war that this webinar is about, which is to do with winning quality and affordable health care for every citizen, every individual who is in India. So I think that's very important, and we need to think about how we are going to spend, and not just the financial resources, but this intense political attention that's been generated by the pandemic. Randeep talked about the preparedness for H1N1 and the kinds of things that you were doing at that point, but they fizzled away. And the one biggest challenge that I'd like to pose to all of us is that we mustn't lose this opportunity that's embedded in the way in which the three authors have titled the chapter 10, Never Let a Good Crisis Go to Waste. But there's every fear that it will go to waste. And whatever we can do amongst the policymakers, the serious providers that we have like Randeep and Devi, the researchers like Gagandeep and Chandrakant, we absolutely must not let this moment go, because I think we will suffer for the next 20 years if we do actually let that thing escape. With that said, let me just try to think about a structure, because none of us have really spoken about the relationship between the public sector and the private sector. And that's going to be dramatically important in improving our healthcare system. And there are ways of thinking about it, a way that certainly I and some of my co-authors, when we did a World Development Report on making services work for poor people, thought about was, health is a situation where you have tremendous asymmetric information. I, as a patient, know very little about my body, but Randeep, when he sees me, he says, you've got this going on in your lungs. Or Devi says, this is, what's going on in your heart. So there's tremendous asymmetric information. There's a tremendous problem of accountability. What I don't know, I can't hold somebody accountable. So you have to think about how states and the center and the government in states will monitor the provision of health services. There are some that are very easy to monitor, and public health and population-oriented outreach type of health is the easiest for the state to monitor. On the other hand, family-oriented healthcare that is understandable within the family is also difficult for the state to monitor. And of course, the most difficult is what happens in an operating theater, what happens with individual-oriented clinical services. And so when we think about the provision of health services in this way, how easy is it for the government or state or the regulator to monitor the provision of health services? Then we have to start thinking about who provides which kind of health service. And I think it gives us a way of thinking about the partnership between the government and private providers. There could be quality providers like Narayana Health. There could be the quacks that we know also hang around and provide health services of absolutely zero value. Indeed, they are destructive in terms of health provision. So I think we need to think about the capacity of the state to be able to monitor, to be able to regulate, and understanding that capacity based on the asymmetric information that is endemic to healthcare provision, that they focus on preventive and public health, which is easy to monitor, that they actually leave the market but well regulated with enough metrics of performance, with indicators that allow the state regulator to understand what's going on through the provision of intelligent data. And now that becomes easier and easier because devices can actually be transmitting data autonomously. There are all kinds of technological things that are available that weren't available even 5 years back. Somebody mentioned this watch, which gives me an ECG that does actually now a SO2 calculation, a oxygen level calculation as well. So it is possible to think about the provision of health services into 2025, for example, which is a real partnership between the private sector in India and the public sector, and how we configure that architecture is going to be dramatically important. I'm so pleased that Gagandeep is the chair of the Lancet Citizens Commission on Reimagining Health Systems in India. I would urge that that's going to be an important ingredient, but I would actually urge all of us to think about a task force, maybe led by independent people, but a task force that is very much Indian. Of course, this is also very much Indian, where we think about what is it that we want our country to be doing in terms of healthcare provision for each and every resident of India. And thinking about that future, I think we need to keep these kinds of considerations in mind, including something that hasn't been said, which is universal health coverage. And that has to be our goal, but it has to be a time-bound goal. And we need to work backwards from that in terms of what the role of the state as a provider, as a regulator, and then as the private sector as a provider is going to be. I think these are the larger challenges that emerge from the lessons of the pandemic. I just want to end by saying this is a fantastic book. The fact that it's a read for medical professionals, it's a read for economists like us, it's a read for government servants. It's an absolutely great introduction to the future of India in terms of its health. Thank you, NK.
Thank you very much, Shekhar, for those outstanding observations. Very pithy. The emphasis on public-private partnership, the need to have an architecture in which all important stakeholders look to the future with a degree of assurance on what the future has really, and the use of technology, what we have learned, and how important stakeholders will have a very creative role to play. Now, I know we are a bit short of time. Maybe we can take one or two questions, but before I do that, can I misuse my privilege of moderator of this great session to ask just one or two questions, since I have the fortune of having all the panelists. Devi may have gone for an important panel. So, when I read the Chandrakant, Gagandeep, and Randeep, when I read this exceedingly fascinating chapter 1 and chapter 2 on the evolution and the ecosystems of viruses in general, I was struck by the fact of how long, in terms of each one of these viruses, good vaccines had taken to gain public acceptance. And what is it that has enabled us to then so quickly produce credible vaccines? What has changed? Has humanity changed? Has the power of technology altered? Has the ability of computing made a fundamental difference? Because the first thing that struck me in reading this fantastic book, and I fully agree with you, Shekhar, that given the style of its presentation and the sweep, this must be a must read for any average Indian. But this is something that struck me. That what has it in which mankind has risen to this challenge? My second question is, and then my last question to all of us, is that, you know, I've handled not a health crisis for understandable reasons, but I've handled, which Shekhar knows, India's balance payments crisis in 91, 92. And this is what, fun thing that was told to me by multilateral institutions was this: India is a great country in its ability to rise to crisis and to challenges. But the alacrity with which it rises to a challenge is the very opposite of the complacency in which it then places itself as soon as a crisis and a challenge is over. That's the point, Shekhar, you are making. How do we make sure that the public consciousness and the change of mindset is a fundamental thing which this pandemic brings about. So I want to address my first question to any of the panelists, particularly Gagandeep, since you are such an iconic researcher. I would like to address that first question of mine, that looking at the fact of what you read in the section 1 of this book and the history of other vendors, how is it that we have come up with credible vaccines, which hopefully will have all the tests and trials to everybody's satisfaction, including yours, to be able to show mankind's response in a manner which has never, ever happened in history. Gagandeep?
So to be less controversial, shall we start with the mRNA vaccines and why we have them? No. We actually have the mRNA vaccines. I'll come to the others very quickly. We actually have the mRNA vaccines because of an investment that Bill Clinton made. And that was an investment in the Vaccine Research Center at the National Institutes of Health in the US. It's the Dale and Betty Bumpers Vaccine Research Center. They were set up to make a vaccine for HIV and they have failed so far. But in terms of the scientists that they brought together, the work that they did, starting from the mid-1990s, they were able to figure out why there were problems with certain vaccines and what it takes to induce a durable immune response to vaccines. So when the sequence of the virus was released on the 10th and some parts 11th of January last year, within 2 days, the Vaccine Research Center was communicating the structure of what needed to be done for an mRNA vaccine to Moderna. And this required a stabilization. The vaccine is based on the spike of the coronavirus, and the spike is a sort of floppy protein that changes shape. So you have to decide which shape of the spike really matters. And they were able to show that it was based on what they had done earlier, that it was the pre-fusion form of the spike that was important, engineer a stabilizing mutation, hand that off to Moderna to make the vaccine. And Pfizer-BioNTech has also made the same stabilizing mutation in their virus. These are new technologies. They have been around only for the last 20, 25 years. We've never had a successful mRNA product for an infectious disease before. And I think it is really building on the backbone of everything that has happened around the world that allowed for these vaccines to happen. If you look at the 2 vaccines, so by the way, I'm vice chair of the board of CEPI, and CEPI funded Moderna and BioNTech and AstraZeneca, and has a grant to Bharat Biotech for a chikungunya vaccine. So
wow. That's saying a lot, Gagandeep, of your iconic knowledge and your global respect. Carry on.
No. So if we look at the AstraZeneca vaccine, that is based on an adenovirus platform that Adrian Hill and the group at the Jenner Institute have been working on for well over a decade now. And they had an ongoing funded program to make a MERS vaccine. MERS is a coronavirus as well. And as soon as this was announced, they switched the MERS program to make a SARS coronavirus vaccine. And they used the same stabilizing mutation that had been developed by the VRC. And the vaccine that is being made by Serum is essentially an identical composition to the AstraZeneca vaccine. With Covaxin, what we have is a company that is innovative, but a technology that is old. So what they are doing is making an inactivated vaccine. And inactivation is something that Louis Pasteur did 170 to 150 years ago. Okay, the rabies vaccine was essentially an inactivated viral vaccine, except that now, since the 1950s, we have had cell culture. We've been able, instead of growing vaccines in animals, we've been growing them in cells, and the inactivated polio vaccine and the inactivated influenza vaccines were the first examples of inactivated vaccines made in cell culture. These were done in the 1950s approximately. So that's the technology that Bharat is using, except that they have now an adjuvant which uses actually molecular approaches to immunology to try and improve the immune response to the inactivated vaccine. So none of this is innovation that suddenly came to light because there was a new virus. It's really investments over years and years and years, effort over years and years and years. And that's why we have these vaccines. And I think it's really going to be a game changer for the next pandemic, because this time we did it in 10 months. Now, why can't we do it in 6 months? I think we can. It requires for us to be able to be prepared in advance for the next pandemics. Where Indian vaccine companies are concerned, I'm actually amazed at how quickly they moved, because they were known for high volume, low value vaccines. What they did very quickly was partner with people around the globe for every kind of technology platform and make sure that they had multiple shots on goal. So Serum actually has 4 different products. Bharat Biotech has 3 products, maybe 4 now, that they are working on. So these companies went out there and found partners for technologies that they didn't have in-house. Really phenomenal efforts.
Thanks. Randeep, you want to add anything to that?
Also, I think Gagandeep has covered it really very well. And I think it's just the advances that we've had in technology and the collaboration that has been possible, like she mentioned, through various scientists coming together, that really helped us get these vaccines so quickly. And it's been an effort, like she said, over the last few decades, which has actually culminated in this.
Thank you. Chandrakant, you want to say anything?
Just reflecting about the rollout of these COVID-19 vaccines. So I think the large-scale vaccination drive, especially for adult population, is going to happen. And this is the first time that such drive would happen for adult population. I think it will be a great opportunity to emphasize the importance of vaccination and immunization in the country, increase the coverage with the existing vaccine, which are delivered largely, but still there is a scope for improvement, and will create a further infrastructure for effective delivery of vaccines and also for adult vaccination in the country.
Preeti?
Preeti, you're muted, sorry.
Sorry. So I just want to add to what Dr. Lahariya was saying, that this vaccination drive will also show our capability in IT. The way the whole system is being, automated, information systems being used productively for monitoring side effects, for registration, for verification. I think this will be a huge success because we are doing it collectively, number one, and secondly, it will also be an opportunity of showing to the world that it is not, again, I would say that it is an interplay of many factors: science, technology, administrative arrangements, everything going together that will make it a success. Another thing that I missed, Dr. Gagandeep Kang had said is that, on research, so this One Health research is also very important. And the first institute has come up in Nagpur. And I think and the Finance Commission can kindly make a note of it, that we must put a lot of emphasis on making it the world class.
Thank you. Shekhar, since you are the ultimate master of today's event, is there a time for one question from the audience? Or we have run out?
No, absolutely. I mean, I think we can, we started on time. We're just 5-7 minutes over what we thought we might end, but we always had a little more provision. So yes, absolutely.
I see a number of questions here, but you choose, Shekhar.
I think there's a question, and certainly it comes to the mind of researchers like us and Professor Kang and Randeep. The role of data and the role of publicly available real-time data is really very, very powerful. And it's not just data for clinical trials and things where everybody's in a kind of emergency ICU mode, the whole country's in an ICU mode. But in the routine running of our health systems, if we can generate more data that's credible, that's believable, that's real time, there's so much more we can do to understand and create the evidence. So I would make a huge pitch for that. And there's a question there about data, but very tragically, it's from an anonymous attendee who has lost their father, and just the lack of information about what happened in the ICU. The inability of the medical profession, and they are under huge strain, so it's not difficult to understand. But this whole notion of the informed citizen, and not everybody can be informed to the point where they will understand exactly what's happening. But nonetheless, I think we need to reduce this information asymmetry, and that would lead to accountability, because then the patient, the citizen, the healthy and the not so healthy, and here we have to think about the silent epidemic of NCDs, non-communicable diseases, they will be able to hold the state, the private provider, the public provider, the regulator much more accountable. So I think that's a question here, but it really is a question to all of us. I don't know if Randeep
Randeep, why don't you?
Thank you, sir. There are two parts of this. One is as far as the individual data and communication is concerned, which I think is important in terms of communication. And communication between the doctor and the patients, based on the data and the condition, is very, very important. But we somehow have not really focused that much, whether it be medical education or it be otherwise, on developing good communication skills. And to some extent, that leads to a lot of sort of problems as far as doctors and patients are concerned. So that is something which should be also based on data. The second part is about data. I think we have a large body of data. There's enormous data that we have, but it's sort of in silos, and there is a lot of unnecessary data protection, if I put it that way. People are reluctant to share data. If we have a huge amount of data, even if you look at the pandemic, there is a large data which is available, which would give us information about what works, what doesn't work, why is there a discrepancy between various things. It could be mortality, it could be comorbidities. Are we missing out on some specific diseases which are prevalent in our country and which is not there in the West? Is past history of tuberculosis an important risk factor? Does it protect? If you have other, say, is malnutrition, we talk of obesity, what about malnutrition? Is malnutrition something that may be a risk factor for more severe COVID-19? So the data is all there. We need to develop a strategy where we are able to get all the data together. It comes on a common platform and is anonymous, but at the same time is open to researchers so that they can look at the data, analyze it, give due sort of acknowledgement or to whoever has given the data. But it should be there, because I think we are missing a huge opportunity, not only for the pandemic, but for many non-communicable diseases, because the data sort of lies in silos rather than, making it one central database which is available for everyone to use.
This is an important point.
For the future.
Here's an important point, Randeep, which you are making. I'm sure Gagandeep would want to agree on the transparency of the huge data which we have. And as Randeep says, that data in silos I think we need to break those silos in larger public interest. Gagandeep, you want to say anything on this availability, management of data and putting them in public domain?
Oh, I agree completely with what Randeep said, no question. But I would like to talk about the first part of what Shekhar had highlighted, which is the idea of communication. And I think too often, I think information asymmetry is a good way to put it, and it applies not only in hospitals, but across all aspects of the health system. And I think one of the reasons for that is cultural. We are an inherently hierarchical, very, very stratified society, and somehow we don't respect people who do not belong to our class or above our class. And I think one of the things that for me really mattered during my medical education was the fact that CMC sends you out in your first year to live in a village for 3 weeks, where you have to spend a lot of time with people who are mostly rural areas in and around Vellore. You really learn about how people live. And that informs the rest of your medical training. You have to keep checking back in with families on how they are doing through the entire time you're in medical school. That really changes how you work. And I think it reflects in the fact that a lot of our graduates are in the most remote parts of the country, because we learned about the lives of people. And when you get to know people, you respect them and you want them to trust you. And the only way you can build that trust is with communication.
Thank you so much. I think that, Shekhar, we should wind up because we are just about. So let me first and foremost thank the NCAER for their continued initiative in this very important area of healthcare, health management, the pandemic, the economics and the science of pandemics, the medical side, and the broader social dimensions. I want to say that I have been privileged to hear the panelists. This is a book which, as I said, apart from the simplicity of style and elegance and anecdotal detail and the numericals which have been used to make it in a Q&A form to all possible readers, is a fascinating journey for anyone wanting to learn about not only the evolution of the current pandemic, but equally on the current challenges and the path for the future. I think this has been quite a learning experience in going through this book. I think the panelists have highlighted. I thought that the Chandrakant, your overarching presentation was brilliant, which brought out all the different aspects of it. And each one of the other two co-authors brought their domain knowledge to the great advantage. So let me, with these words, thank you once again, Shekhar, for the privilege you gave me of chairing this very, very important session. I have myself learned a lot, but I'm leaving today's session with one degree of satisfaction, of which many of you have been contributors, that many of the recommendations in the Finance Commission, which we have made, and the awards which we have given, has been informed by quite a few of these ideas, which have come up repeatedly once again. So thank you very much and wish you all the best. Thanks.
And let me just thank everybody on behalf of NCER for doing this. I do want to throw a challenge right at the very end. I want to challenge our three eminent authors, Gagandeep, Randeep, and Chandrakant, that we need a book from them about a year from now that kind of reflects on what actually India did after it beat the pandemic and after we won the war on coronavirus. I think we need a sequel to this that actually says, what did we do with this great, grand opportunity to completely change the trajectory of healthcare for every Indian. So that's the challenge to you, to Penguin, to all of us who are really interested in this idea. Again, thank you very much. Good night, and please stay safe. And NK, thank you.